Hi, this is Brian Kim. I'm going to share with you this case of a patient who had severe debilitating negative dysphotopsia in her first eye, which was her left eye. And so now she's coming in for cataract surgery on her right eye, and we're trying to find the best way to help avoid or reduce the risk of negative dysphotopsia in her right eye. What I decided to do was implant a 3-piece intraocular lens into the capsular bag and then reverse optic capture the lens. So you'll see this case from beginning to end, and you're going to see I'm going to make a smaller size rexus to more effectively reverse optic capture, and you're going to see how easily I'm able to reverse optic capture using the INA handpiece. So go ahead and mark the center of the cornea with my corneal marker, which will help me center and size my rexus. I'm using a paracentesis blade to make an incision, first inferiorly and then superiorly, making sure I'm flat to the iris plane to get a nice corneal shelf. I'm injecting some intracameral lidocaine and then dispersive viscoelastic to fill the anterior chamber. And then I'm doing the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel the blade through the cornea, and then use a cannula to turn the eye toward me, and then enter. And this is a triplanar corneal incision. And so for the rexus, again, if you're wanting to do reverse optic capture, you want to make a rexus that's quite a bit smaller than your normal size rexus. And so I'm going to start with my puncture style rexus using the forceps. And as I pull it down, I'm going to make sure that I don't make it too large. And so that's really the key. I'm finding the edge of the flap on the right side, and I'm going around circumferentially. So you can see the rexus is not really terribly tiny, but I'm making sure that it's about 1 millimeter or so smaller than my corneal marks. And once the rexus is completed, I'm burping some viscoelastic from the anterior chamber. And this is the capsular fornix hydrodissection technique. I'm placing the cannula out to the contralateral equator underneath the rexus edge. Point the tip down, you get a nice fluid wave. I'm loosening it up on the left side, and you can see the lens is already spinning quite nicely. I'm irrigating the surface of the eye. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material, get underneath the epinuclear ridge with the chopper, point the phaco tip vertically subincisionally, crushing the lens in half. That's the double chop maneuver. I place the chopper out across the contralateral equator, pulling it centrally towards the phaco tip, and that crushes the right heminucleus. That's the cross chop maneuver. I'm using a little bit of vacuum in the chopper to pull that first quadrant up, crushing it in half, and then emulsifying the lens pieces. Place the chopper underneath the capsular rexus edge and out to the equator around that second quadrant. I pulled it up out of the bag and start crushing it with mechanical fracturing forces and emulsifying the lens piece. This is a remnant of that second quadrant. I'm using the chopper to pull it up very carefully and then crushing it and emulsifying the lens piece. I'm rotating the second heminucleus in front of me, placing the chopper out to the equator, pulling it centrally and crushing it against the phaco tip, which is held deep in the bag, crushing and sandwiching the lens piece. Do the same maneuver, crushing that third quadrant, sandwiching the lens piece between the chopper and the phaco tip, and emulsifying the lens pieces. This is the fourth and last quadrant. I place the chopper around the lens piece, crushing it against the phaco tip, and then using high vacuum and ultrasonic energy to emulsify the lens pieces. And this is the last part of that fourth quadrant. I just used a chopper to pull it, and it kind of turned. and then I crushed it with the chopper and the phaco tip and start emulsifying the lens pieces. Once the endonucleus is gone, I'm using high vacuum to remove the epinucleus. I take the chopper out, push BSS in, take the phaco tip out, and then replace it with the INA handpiece. I'm starting subincisionally. Again, I'm getting a little bit of a ballooning effect on the conj. I use my cannula to kind of help stretch the conjunctiva around the incision. I'm starting subincisionally, removing the cortical material first, and then I'm going around circumferentially, making sure I grab the cortex on the anterior aspect closest to the capsular rhexis edge so that the cortex peels from anterior to posterior. This helps reduce any of those fine cortical wisps that you might have. So once the cortex is removed, you can see the bag is pretty clean. I turn the port down, and with foot pedal modulation, I carefully remove some fine cortical wisps that are attached to the posterior capsule surface. I switch then to the polish mode, polishing underneath the anterior capsule rhexis edge, sweeping side to side, making sure there's no remaining lens material. We're using a BSS cannula to pulse the subincisional capsular fornix, which was clean. I'm injecting some cohesive viscoelastic to inflate the capsular bag, and then I'm using the capsule sweep to polish first on the left side, making sure I'm removing of that cortical material and lens epithelial cells from underneath the anterior capsular rhexis edge, and then I'm polishing on the right side as well. I chose to use a different lens in this case just to make sure, compared to the other lens, which is a SA60 AT lens. I chose to put in a CT Lucia 602 lens from Zeiss. And so I'm going to widen the incision because this is a three-piece lens. I'm using the 3mm blade, and I'm just kind of sweeping it side to side, which is going to help enlarge my incision. I'm able to place the three-piece intraocular lens into the capsular bag, bevel down, and then I turn the bevel towards the left. As the leading haptic is going into the anterior chamber, I'm making sure that the leading haptic goes into the capsular bag. Once the optic is delivered, I'm able to dial in the trailing haptic using the Maltzman into the capsular bag. I go in with the INA handpiece and go underneath the optic, tilting the lens and removing the viscoelastic from within the bag. And then polishing underneath the anterior capsular rhexis edge to remove any lens epithelial cells. So I'm going underneath the lens itself and just doing a little bit more polishing of the posterior capsule. I can see some fine lens material there, and I go back and do a little bit more polishing. Once I'm done with that, I'm removing the viscoelastic from the anterior chamber. There's very nice overlap of the lens and the capsular rhexis. So once the viscoelastic's out of the anterior chamber, I go underneath the lens, and you can see I'm using the tip to get under it and then sliding it towards me temporally. That pops up the optic out of the bag, and I'm able to slide the INA out, and now the lens is reverse optic captured. You can see that by the blue outline here. It looks like a lenticular form, almost like an almond shape. This is a sign that there's good reverse optic capture. And what this does is the haptics are in the bag, but the optic is anterior to the bag. By having the optic closer towards the iris, it helps reduce the risk of that shadow from the negative dysphotopsia. Interestingly enough, this does in theory cause the lens to sit a little bit more anterior, and I did choose a lens power that was slightly plus. It was around 0.2, and so the patient actually ended up with a -0.5 plus a half refractive error. The patient had 20/20 vision uncorrected and had no negative dysphotopsia. So I hope this was helpful to you, and I thank you for your attention.